बैठे हैं, बस कुछ है कि वहीं पे बैठे बैठे you can take picture if you want to take, and I will not say much, but I am going to invite Indian American Forum की founder इंदु जायसवाल जी. इंदु जायसवाल जी के लिए मैं कुछ बोलना चाहती हूँ. She doesn't like people talk about her, but I want to say something. She is the Indian leader in Long Island. When I came in 80s over here, I just used to see her pictures and what she's doing, and she motivated lots of people, including me, how to do for community work, selflessly. And selflessly she's working, not anything in return. So many programs she's doing in Nassau County, Diwali, and you name it, patriotic programs, and then Indo-American Night in Eisenhower Park, and so many programs for the community. And also from profession, she is a dietitian. She works full time, but still she comes to all the programs. Please welcome Indu Jaiswal.
Jyoti ji, thank you for those kind words. Namaste, good evening, friends. Thanks to all of you for coming today and joining us for this very special presentation. We are going to request our incoming President Vimaji, please. Before I go further, Vimaji, would you like to say a few words?
Yeah, sure, of course. Well, I would like to welcome everyone, first of all, and thank you for being here. And I know this topic that we have very, very qualified physicians here who can really tell you what to do and how to take care of this. Because we know colon cancer is a serious issue. And I tell you, my wife actually makes me go for colonoscopy every 5 years. And last time I tell you what happened, when I went, this was the second time, and I went into the doctor's office after I woke up and everything, and you know what I said? I said, give me the bad news. And he said, there is no bad news. I said, thank you very much. I'm going home. There's no more talking. There's no point in talking anymore. But this is very serious matter. It's good that my wife gets after me to go for it. I mean, 2 days of torture that you have to go through, but that's well worth it. One of my golf coach was telling me that he had to go for colonoscopy once, and he was told not to eat, but he just kept eating whatever. Wow. Next day when he went through it, the doctor told him afterwards that, listen, we couldn't see anything. It was all fuzzy in there. So, I mean, that's very important that you have to go through whatever you have to go through to make sure that you get what you need and you get the proper results. But anyway, I won't take any more time, and I will let everyone else speak. Thank you very much for being here.
Thank you, Vimalji. So, March actually is a very, very important month. See, I'm a dietitian, so I'm being told I always forget. But March is also the National Nutrition Month, and Colon Cancer Awareness Month, and Social Services Month. So I met Preeti ji 2 weeks ago, and we said, okay, we'll do a nice presentation for colon cancer awareness. And like what Vimal just said, do the colonoscopy is not a problem. We have all gone through it. It's very, very important. And we have in our, audience today, Dr. Arya, who is a retired, well-known gastroenterologist, who can vouch for the GI issues and the importance of, prevention and treatment. And Dr. Mrs. Arya, who is the past member of National President of AIA, made a very big donation yesterday for the school, which we are very thankful and we are very proud of you. And congratulations for helping our students. So over here on the left hand side we have Bina Kothari ji, President of AIA. She did a tremendous wonderful job with the President of Indo-American Voice and a member of Indian American Forum. We have some members of Indian American Forum here. We'll be acknowledging them. Vijay ji is here, Jyoti ji, all the senior programs that you see that we are running. These are the, pilots who are running the, running the show, and the drivers in the bus. So, going back to our panel. So, we want to welcome Dr. Preeti Mehta. She is a very brilliant, bright, young, enterprising GI specialist. Dr. Jack Kalra. Dr. Jack Kalra, we know like a vintage oncologist. We know, I'm not saying she's old, but we know her. And we have Dr. Mehta again. So, Mehta Group has, like somebody asked me, are these the same people who are opening the public center in Hicksville? I said, yeah, they are the same people. So, they want to hear from Dr. Mehta. They want to hear about the importance of prevention. They want to hear about how, colon cancer can be detected and treated at different stages. We also had I was speechless. We had a program by Dr. Preeti Mehta about 2 years ago on Zoom. I hope I still have the recording. Dr. Mehta did not stop. I mean, she went on for about half an hour. Such a brilliant presentation. I said, Preeti ji, I'm so proud of you for what you have done. The way she explains everything and how, she's able to treat her patients. So, Dr. Mehta has her office people, they brought a TV to show the slides. So, while they are setting up the TV, would you like to say a few words?
Just I want to tell them if you want to sing over here. Do you want this to be here?
Good evening, everyone. Namaste. Jai Hind. I'd like to invite everyone today. Thank you for coming, taking time out of your schedules for this very important topic. And this is something which impacts not just us, it impacts the younger generation, probably your kids, or if some of you have kids that are older. This impacts entire society. So colon cancer has got increased publicity in the last few years after having had some national film stars and actors who were diagnosed with colon cancer at an early age. And that's what has brought it to the limelight. But the key is, today, the number one cause of deaths from cancer in people under the age of 50 is now colon cancer. So there's now this rush and this desire, the need to prevent this cancer, which is increasing and has doubled over the last few years. So that's very alarming, and I think that's why I'd like to have the presentation to show you a few things. Some of you probably are already aware of how colonoscopy is, what it identifies, and what we do during colonoscopy. I think that would be something which you will enjoy to see. But I think it's a very important topic, very relevant. Thank you so much for organizing this, Indraji. It is something which we do every day, but then I believe it's in the heart and it should be on everybody's mind, and everybody should have a good understanding of this condition, which is deadly but is 100% preventable. That's very important. Even colon cancer, once diagnosed, is preventable and treatable. So slogan is preventable, treatable, and beatable. So that's something which we should keep in mind. I'll let everybody else talk. Dr. Kaul is also an expert oncologist. When we diagnose these cases, we typically will refer them to her. Some of them will require surgery, some require oncology. But that's more in the earlier or later stages that you need oncology. Luckily, we are able to prevent it in many of the cases. However, it's unfortunate that after it's diagnosed, there are some options. Chemotherapy has become very effective, but I'll let you speak for it before we talk a little more about the presentation.
Welcome everybody. I wanted to just add, these are younger kids. He is going to go through what has changed in colon cancer. At age 50 used to be colonoscopy, and now it's age 40. So please remember that. Age 40, families, he's going to go all through, but just to start. And then I really want to appreciate your parents are here. Wow, look at that. Mr. Kaul and Mrs. Kaul were just recognized by IAM him is, he said, what's the bad news? Why do you expect the bad news if you go properly for your colonoscopy? Only expect positive, beatable cancer, recognizable at early age, but we have to know when to do it. Prevention of cancer is the most important thing these days. Cancer is so common. It's the most common cause of death in males and females combined. For males, lung cancer still leads and prostate cancer, female breast cancer, but combined, it's a colon cancer. So it's a must. It's also a multiple myeloma and gallbladder awareness this month, but you're going to be talking about colon cancer. So with that, please show us the slides, and I want to know the new indications from you.
Good evening. Thank you so much for taking your time to come out on Thursday evening. So really appreciate it. I think I can't appreciate Inuji because we just talked about this about 3 weeks ago, and I said, listen, it's March, it's Colon Cancer Awareness Month. Let's really organize something for our community. And I think you guys are already all aware, which is incredible, and I think you should all pat yourself on the back about knowing about what colonoscopy is, knowing about the age, when to get screened. So I really appreciate you for organizing this within like 3 weeks or so. Dr. Arya, thank you so much. Oh my God, he's the guru, he's our teacher. So we're very thankful for you to be here. If you say something wrong, please chime in and say, Dr. Preeti, what are you saying? Dr. Nilesh, what are you saying? So thank you for being here. I think everybody here has, both Dr. Carla and Nilesh had said that it's so important. I know it is a very, it's a scary procedure, right? When people come to me in my office, they are always concerned about, wait, Dr. Mehta, it's going to be someone who's going to put a tube, in all reality, they're going to put a tube from my butt and I'm going to be sleeping and I don't know what's going to happen. So in reality, when people don't have the medical background, that's what they're thinking. So I'm going to be sleeping, I'm not going to know what's going to happen to me, and so it's a very scary procedure. However, given what we are noticing, obviously you guys know about insurances, and for insurance companies to actually pay us at, when patients, at 50, they were supposed to get a colonoscopy, but now they're paying us for patients to get their colonoscopy at the age of 45. That means truly for insurances to pay gastroenterologists at the age of 45. So you can understand how much cancer is going around, how much important it is to prevent colon cancer. And that's why I would say that, being here, being aware, I think it's also important to communicate, right? A lot of patients, when they're nervous about getting their colonoscopies, I tell them, listen, I did it. I did my colonoscopy, I shared my experience with them. So obviously, if all of you guys have had their colonoscopies, I would love for you to share this knowledge that, listen, it was, 1 day of pain, but then, listen, I prevented colon cancer. We're not living in a third world country, right? We're living in America where we actually have insurance, we have availability, we have accessibility. Why not do it? What's the worry? What really is the worry? And if there is any worry, listen, talk to the doctor. Find a good doctor, find someone who will sit with you eye to eye and just talk about it. Listen, I'm scared, I'm worried about anesthesia, I'm worried about drinking the medication. Where there's a will, there's always a way, right? And you also have to seek out a doctor who's willing to sit in the room, right? Sit with you for 15, 20, 30 minutes, maybe 45 minutes you need. But we do that, right? We have, as you can see, I'm sure, this is our practice. While they set up all of this, I'm so sorry, we're just going to talk a little bit about this. We have a practice, we are a group of 20 doctors. We are all the way from Queens to Nassau to Suffolk, 20 gastroenterologists. We have 2 large ambulatory surgical centers. You don't have to go to the hospital to do the procedures. You don't have to wait for hours in the hospital. You can come get a consultation. If patients are healthy and young, I don't even need to see them. We can directly open access, provide them consultation over the phone and get them done. But again, that's the point is, we are a big group. We have a lot of PAs, nurse practitioners, who we counsel, we coach, we train. to be able to communicate all the things that we're able to communicate as physicians. So don't hesitate to reach out and really screen. But I would like to hear with a raise of hands, how many of you guys have had your colonoscopies?
55.
Wow, this is... Hello?
So my husband did.
Your husband did?
Yes. I told him I did a trial and everyone.
You did? Good. Listen.
No, I have absolutely.
Ulcerative colitis, there you go. So there's
I want
another...
to say something when.
Yes, 110%, right? Listen, so you're not fearful. You've had it so many times. So you know what it entails. And again, the most important thing is when a person shares with another person. You're just like, you know, how you say that it takes a village to raise a family, right? Same thing here, right? It takes one person to go and make your daughters aware, your sons aware, your cousins aware that, listen, don't be scared. It's okay to talk about bowel movements. You know, patients, I tell them, listen, guys, show me pictures. Because when you come and talk to me that after I'm having blood, is it okay if I show you my picture? Is it okay? Like, no, that's what tells me what's going on. So being shy and afraid is old age. No more. For what? So most important thing, it's okay to talk about your bowel habits. I want to emphasize, while we get this all up, talk about your bowel habits, talk about your symptoms, talk to your doctor. Don't just go to a doctor and say, oh, my doctor knows. I hate that word. Majority, to be honest, and it's our community, even educated and well bunch of group, when they come to me and when they ask me, what medications are you taking? Oh, the doctor knows. You can just get it from my file. So let's not be those people. Let's be those people who's aware of what medical problems I have, what medications I'm taking. I take 1,000 pictures of everybody in pictures. Take your picture of your medications. Put it in your phone. Easy. But the whole point is, listen, you guys are in America. We're not in a third world country. We have doctors. Please go seek out, ask all the questions. Don't hesitate. You were saying something.
Yes.
Yes.
It mostly works with large intestines. And then, yeah, and then pancreas, and then, pancreatic cancer.
Yes.
And then colon cancer. All of these kind of, they start feeding in.
Yes.
And the most important thing is what you take. I mean, it's your stomach. It's your stomach, it's your body, right? So in the early stages, when you go ahead, and I'm sure you're going to cover this in the presentation, because bowel is not something that you go on a regular test. I do my blood test, I do my sugar test, but bowel is not something that you do a regular test on. And if there is a variation, even in the color, and this is what I learned from my son, by the way. It's good to have a doctor in the family.
Absolutely.
You learn all this.
Yes.
So if you have a color change in there, that would be a good time to go ahead and start thinking about it seriously. Is that the truth?
Absolutely. So I think, see, presentation, I don't care, but I think I like to have a conversation just like this, right? So you're right. There's no really, when you go to your primary care physician, they just talk about, okay, let's do your blood work, let's do your EKG, let's do your cholesterol level. Do they actually talk about, hey, how are your bowel movements? But a good primary care physician always asks their patient, did you get your colonoscopy?
Yes.
Right?
Yeah.
So a good primary care physician.
Right.
So just to let you know, there are many physicians out there, but a good physician, that is how they will ask is, hey,
Yes.
did you prevent? Did you go get your mammogram? Did you go get your pap smear? Did you get your bone density? And did you get your colonoscopy?
Yes.
Correct?
Yes.
But so that's one way. But of course, as patients, doctors never ask, how are your bowel movements? Or doctors never ask, are you seeing any blood in your stool? Because that's not what they're really looking at. They're just basic in terms of their diabetes, their cholesterol, making sure there's nothing wrong. But in the blood work, what ends up happening is a doctor does check the hemoglobin and hematocrit, right? So you're right, they don't talk about bowels, but they can look at your blood counts. And they can see, oh my God, wait, why are you anemic? Right? Why is your hemoglobin and hematocrit low? Why is your iron level low? So that's the second way a primary care physician can say that, are you losing blood from your stool? Is that the reason why you're iron deficient, or what's going on? So that's another trigger, right? But what we need to do, and that's the reason that we kind of came here about this, is that we do want to talk about if you guys notice that there's any change in bowel habits, right? So most people say I go every day or every other day. But a lot of patients, when they come to us, they say, Dr. Mehta, this was my regular habit. However, in the past 6 months, I've noticed I'm not going like the way I used to.
Yeah.
That, Dr. Mehta, I'm very constipated. I used to never be like that. And then I never changed my diet, my habits, nothing changed. But what's going on? So that's another trigger. So as patients, we have to unfortunately bring this topic to our physicians, right? Because our physicians are not going to care about, hey, how are your bowel habits, or how many times are you going? Because those are things that they're not really talking about. They're really talking about just prevention. And that's where your mammo, your PAPs, your colonoscopy, but they don't talk about that stuff, right? Obviously, we also have to be not shy to say, Dr. Mehta or your primary care, I'm seeing some blood in my stool. It's weird. I don't know, I see there is streaks on my stool. A lot of patients go and talk about that and they say, could it be hemorrhoids, right? So don't be afraid again, right? Because we are knowledgeable and intelligent enough, but there are many patients who are very shy and they don't really want to go out and tell that. So it's important for us to be able to communicate, right? Communication is key to success, and that's where we have to bring it ourselves. I have a change in my bowel habit. I'm not going every day, or I'm going too much. I'm having too much diarrhea. Or I'm having a lot of blood in my stool, or I'm having changes in my stomach. I eat and I hurt and I have to run to the bathroom. So these are all symptoms. But again, it comes back to your primary care when they ask, how are you doing? How are you doing? Are you doing okay? Are you doing well? Any symptoms, any problems? But sometimes we're shy to present specifically about our bowel habits and blood and this and that, but we need to. But the only way a primary care would be doing any much of this is that until unless we don't give history, they won't know. And until unless their objective findings are what? Well, she's anemic, her iron levels are low. Or, wow, wait, she's 45 and she needs a colonoscopy. So that's the main way that they can really tell and talk to you. But we have to present it, and that's exactly what you said. We have to come across to them. Yes,
Can I say?
Of course.
I think this is like awakening thing for me. I was only 1991, I was diagnosed with colon cancer. And I was like back and forth to the hospital 4 weeks, 6 weeks with the interveners. They told me they had given me enough steroids, no, I need a surgery. In March, I showed them a thumb, no surgery. In June, I wound up in emergency Mount Sinai, where I had my 3 sections surgery, J pouch. And that time the surgery was very new. After 25 years, I got a revision of my pouch in NYU. Dr. Professor Ramsey did that. But I tell you that my sister, she's a doctor, and we are going shopping, and she said, why you keep on going to the bathroom? And I told her, Didi, that I am having a cancer, and she said, go to this Dr. Cusa, Jared Cusa in Siasset, and I think you have a colitis. She did that. And now,
But you mentioned to them that I'm going to the bathroom a lot.
yeah.
So it's you.
Yeah, mine was, it started with a constipation, and then now my husband, 10 years ago, he's a liver transplant patient, and 2 months ago he was diagnosed, he had a pouchitis. So they, not pouchitis, appendicitis. So they removed the appendix, did a biopsy, found out he has a cancer. So thank God his colon part is okay, liver is okay, but he took out 3 inches of colon. So I tell everybody to go for colonoscopy. I had a 50 of them done. And if I am standing here because of that, and my dear friend Indu, she was all the time helping me. Now Jag also, everything I want to oncology, ask her, she's a big helper. Thank you.
Ravinder, for sharing your experience. That was very important. Let's go over the presentation, and then people can ask questions. I'm sure we'll have lots of questions for you today.
So the presentation is more like bringing up the points to discuss. It's an outline. If you feel you have some questions, please interrupt me, because this is not a It's not a lecture where you go to sleep. I'll be quizzing you, I'll be questioning you, and I want you to ask me questions. So,
I think before we just do one thing.
Does everybody here know that the new screening age for colon cancer is what?
45. That's
Perfect, now my lecture is done. 45, right? So every single person here should know that it's not 50 anymore. It's 45, right? And that's, we're going to get into the family history exactly. And if you have a family history of colon cancer, it's the age of 14. But there are other types of cancer we'll get into, but again, let me give you some statistics, okay?
so I think you can just open up. So a few questions I'll ask, and let's see how aware I think our crowd is very intelligent, so we should get all these questions right. Let's talk about the first question. Is colon cancer more common in men or women?
Both. I should say both.
That's a myth that people think it's always more common in men. That's not true. It's common in men and women, almost equal. So a lot of women actually would, just like we feel that women don't get heart disease, but after the age of 45, 50, women also start getting heart disease, and we tend to ignore ourselves, and most of the women would think, they don't think about themselves as having heart problems the same way. Colon cancer is common both in men and women. So if women think that they're at a lower risk, please. They're not ahead of men in this, but they're almost the same. Second question. If I don't have any symptoms, I don't need a colonoscopy. Okay, so the crowd is really, really educated on this. I think Preeti beat home the point very well. It's called a screening colonoscopy. Screening means you perform a test on someone who has no symptoms. That means you're healthy, you don't have a problem, but you still get a colonoscopy, unfortunately. So it's called a screening because just like you get a pap smear and a mammogram, you don't have any problems, you do it routinely. So why would you do a test routinely? Why would you do a test in everybody routinely? So two or three reasons why you should know. One, colon cancer is very common. So when something is very, very common, you have to do it. Second, it's actually in the early stages of colon cancer, you don't have any symptoms at all. So most people with colon cancer, they have a full-blown cancer. They have a tumor as big as a tennis ball in their colon, in their large intestine, but they have no symptoms at all. So we find a lot of people who come to us for the first colonoscopy, they're just 50 years old, 46 years old, 48 years old, and they have a full-blown cancer, and I ask them, do you have any symptoms? Yeah, I've been having some things in the last 6 months, but really nothing much. So a lot of the people don't have symptoms. That's why you do a screening test. You do it for everybody. Why do you start at the age of 45? Why don't we start at 55, 65, or never do it? Beneficial. So you start at that age. You have to have some kind of cutoff because colon cancer increases with age. So actually it's interesting. Do you think colon cancer is more common over the age of 50 today, after everything, or it's more common in people less than 50?
Less than 50.
Why would it be common in people who are less than 50 compared to more than 50? Well, because everybody over the age of 50 is getting colonoscopies and getting tested. So colon cancer over the age of 50 has gone down dramatically, actually. Next question. A colonoscopy can reduce your risk of colon cancer by 80 to 90%. Yes. I think it's true or false?
True.
Absolutely true. So it's surprising. One colonoscopy, how does that happen? Well, because during the colonoscopy you find polyps, you take them out. What is a polyp? A polyp is a growth in your large intestine which slowly becomes big and big over time. And before it becomes big, before it becomes cancer, you take it out. So you prevented the cancer, just like you do for pap smears or mammograms. In mammogram, you find one spot that's abnormal, you do a biopsy, you take a small lump of the breast out and you cure. Same way, you take the polyp out and you're cured completely. Final question. Vegetarians don't get colon cancer. Okay, so there's a clear response here. Everybody gets colon cancer. It's not sparing men or women. But if I were to ask people, what do you think are some of the risk factors for colon cancer? Who are the people who get colon cancer? There's a lot of reasons why people get colon cancer. But let's start with what do you think some of the common reasons for colon cancer would be, or what increases your risk for colon cancer? Any hands? So a family history of colon cancer actually increases your risk for colon cancer significantly. When you say a family history, it could be anybody. It's not your wife or your spouse, it's your parents or your children. So even if you have a child who develops colon cancer at the age of 45 and you've never had a colonoscopy, you're at a higher risk because they have your same genes. So it's called as a first degree relative, which means if it's your brother, your sister, your parents, and it's not just if they have colon cancer, even if they have large polyps, you also have a higher risk. So you end up getting a colonoscopy actually earlier than what you would typically get. So if you have 1 or 2 family members with colon cancer, then you start doing a colonoscopy at the age of 40. Rather than 45. So a lot of people will get colonoscopies even earlier than that. What do you think are the other risk factors or certain things you think in our diet or foods that can actually increase colon cancer? Yes. Red meat and processed meats. Actually, processed meats and red meats. FDA, sugar will lead to obesity, which is also increasing risk for colon cancer, that's right?
Environmental pollution and heavy metal toxicity.
So metals, microplastics, there's more and more data now showing that they increase risk for colon cancer. You saying something?
Yeah, my comment is that toxic food.
So ultra-processed foods or highly processed foods is what he's referring to.
So why don't we invest resources and manpower to shut them off?
Yeah.
That's a very good question. It's a political question, but it's a very valid point because what he's trying to say is if you are telling me that processed foods are causing colon cancer, if microplastics in food, if red meat and processed meats actually cause colon cancer, why aren't we taking the steps that are necessary to prevent? The problem with a lot of the ultra-processed foods in this country is my personal take. It's all commercialization, there's a lot of lobbying, there's a lot of other variables that impact how the industry works in this country.
But then we are not nipping the evil in the bud.
Correct. So you're not solving the problem.
We are
You're
waiting for the damage to be done, and then you guys come.
Correct.
Start doing the thing.
But the advantage of a session like this is, if we understand that ultra-processed foods actually cause cancer, we can change our habits like a lot of the people here have. And I do the same thing in my office. When someone in my office orders food and orders a Coke or a soda, and I go around everybody, guys, there's someone who ordered a soda. I don't know who ordered it, but whoever orders it doesn't get a raise next year. Anyway, so what I'm trying to say is, we used to have some free lunches in the office, and after 3 months of free lunches, everybody started gaining weight, and I said, no more free lunches, guys. Because obesity increases the risk of colon cancer. घर का खाना लाओ या मत खाओ. Perfect. बिल्कुल सही कहा. घर का खाओ. That is the best because that's not processed food, right? It's not ultra processed like you would get outside. Another thing that you raised is sugar or like high fructose corn syrup, sugar, or these carbohydrates, which are the small sugars in any form. A lot of the sugary foods actually will lead to diabetes. Diabetes is associated with metabolic syndrome, fatty liver, and actually diabetes increases or obesity increases multiple cancers in the body. Ovarian cancer, breast cancer, there's a lot of other cancers. So Preeti's pointing me that she's worked hard to get the slides done. I'm just kidding. So we talked about the new age. 45 is the new 50, maybe I'll say that. But a big problem that people worry about is colonoscopy preps. So we got some preps here, and preps have changed dramatically in the last few years. The amount of prep you're drinking has changed so much. People used to worry about throwing up the medications, drinking a lot. So previously we had a gallon of medication that he had to drink. And what that did was basically, I call it my roto-rooter because it's flushing your entire colon out. That's what it was doing. And now we have 2 small bottles that you drink with water. So it's a concentrated liquid. There's also pills in the market where you just eat multiple pills and drink plain water or Gatorade with it. So the prep also has become easier in terms of what you're drinking. Excellent. So the talk is very relevant today given the fact that colon cancer, if you look at 1 in 5 people below 55 will have a risk of getting colon cancer, which is very, very high. The number of cases have doubled in the last 2 decades, and that is a very worrisome trend. Because of that, the guidelines have recommended starting colonoscopy and colon cancer screening at a younger age. Go ahead. So there are multiple societies, there are multiple different societies in the medical world that all endorse colonoscopy starting at a younger age. And this is the question now that has come up is there are people who've been getting colon cancer even at the age of less than 45. So the question is, will the guideline go down? Well, we'll follow the trends, but even today, if you look at this age group, between the age of 45 to 50, only 10% of the people get their colon cancer testing. And that is a big problem. Over the age of 50, about 60 to 70% of the people have got themselves tested. 70% is still high because it's New York. In many other parts of the country, it's even lower. But only 10-12% of the people within this younger age group have had some tests. And that is the concern, and that's why the increased awareness is important. Now, some of the myths of colon cancer, that colonoscopy is painful.
Is it painful?
How many of you would say it is a colonoscopy is really painful? So it used to be in the past, a colonoscopy would be painful for only a few reasons. So in the past when we used to give different kind of anesthesia, we would not put the patient completely asleep. It used to be a little uncomfortable. In the past we used to use air to inflate the colon. So the air would make you feel very bloated and that gas in the belly would make you very uncomfortable. But that has changed completely today. So we give anesthesia to everybody so you're sleeping. People actually get up and fight with me saying you didn't do my colonoscopy.
Anesthesia is very good.
Without the anesthesia, there's no pain at all.
So it's usually most people say it's the best sleep of your life.
Yeah.
So you feel more refreshed than anything.
It actually feels like a normal, natural sleep. People feel like they actually slept at night and woke up in the morning. And if they say that actually, I think, how long was the procedure? And I tell them it's only half an hour. They say, oh my God, it felt like I slept for 8 hours. I feel so fresh. Because the medication we give is called propofol, which has got a bad name for other reasons. But when given properly in the right setting, with anesthesiology monitoring you, it's very safe, it's very effective. And the reason why it's very safe is because someone's monitoring you, but it reverses very rapidly. So when the procedure gets done, you wake up in 10 minutes. And you don't get any nausea, you don't throw up. It feels like a natural sleep. The waking up is also very natural. And that's why people like it. So this is some of the things that you could possibly control. We didn't talk about smoking and alcohol. Smoking definitely increases risk for colon cancer. Alcohol, we never talk about alcohol. Is actually, there was a myth in the past where people used to say, well, having a glass of wine actually decreases heart disease. That's not true either. Actually, alcohol causes 7 or 8 different cancers in the body, which you need to be aware about, right from oral, esophageal, breast cancer in women, colon cancer, pancreatic cancer, stomach cancer. They're very common. All have been attributed directly to alcohol. Smoking, we know about lung cancer, but smoking definitely also increases risk for colon cancer. So these are some of the modifiable risk factors. We didn't talk about a sedentary lifestyle or inactivity, which directly or indirectly is related to actually obesity. Exercise reduces weight, reduces obesity, and that has a great impact. Now, in the last 4 or 5 years, people have used medications to reduce weight, and that works beautifully, and it's very effective, whatever it takes to lose the weight, right? So it could be diet, exercise. Yes, Floroji.
Does Mounjaro conflict with any of your processes, pre-processes?
So the question is, if you take a medication like Ozempic, Mounjaro, Wegovy, does it affect the procedure? It doesn't affect the procedure, however, because some of these medications slow down your stomach, we have to stop the medication. So we ask people to stop the medication for 1 to 2 weeks before the procedure. So you skip a dose of the medication before you come for the procedure. Because if you take the medication, your stomach doesn't empty. When we give anesthesia, we want the stomach to be completely empty, because if you start retching or something happens, the fluid in the stomach comes up and you're completely sleepy. We don't put any tube in your mouth, you're sleeping like normal. There's a risk of that fluid going into your lungs. That's why we stop any of these medications, we stop them before. We also, yes?
Just FYI, Nilesh, that nowadays the medical community, and especially the nutrition, they are not in favor of the Ozempic because it is not the weight loss medication. It's a hormone. We all have a GLP in our system and we need to activate that. So this is what the patient needs to learn. And those who are on the Ozempic, they must have registered dietitian working with them. So this is what the physician has to know, because the sarcopenia is kicking in.
Correct. So there's different ways in which a lot of these weight loss medications work.
So all of my patients who are coming in for a colonoscopy, not only do we tell them to stop their medication a week before, but I actually take an extra step and tell them to take 1 capsule of Miralax at least 2 weeks prior to the procedure, because as you know, the most important thing for the colonoscopy is that you're supposed to have a very clean prep, right? In order for me to look at your colon, I don't want to see stool, right? I want to see your pink, beautiful, pretty colon. It should be spick and span. So that's one thing how Ozempic, Mounjaro, all these can affect. So just be mindful if anybody is on. And again, those are good medications. We're diabetics. You lose weight. It's good glycemic index and everything. Mindful.
But some people are making a misuse of those medications.
Listen, I have.
It's not for colonoscopy.
Yeah.
Can we keep the comments?
So I think everybody knows, right? The risk factors for colon cancer. We just talked about diet, alcohol, smoking, etc. But one of the most important risk factors that we should always know is family history, right? If you guys have a first-degree relative, meaning if your parents have a history of colon cancer, if your brothers or sisters have a history of colon cancer, those patients need to be evaluated for their colonoscopy, not at the age of 45, but they're supposed to be coming at the age of 40. Or the other rule is that if you have, if the age is, if your mother or your father or if your brother or sister got diagnosed at the age of 60, then again 40. But if they're diagnosed even younger, then they go even younger, like 30 years and etc. Other causes of colon cancer are obviously something called inflammatory bowel disease, which is patients who have ulcerative colitis or patients who have Crohn's disease. These are inflammations that are happening in your colon. Now imagine if over time this inflammation continues to build up. Every 10 years, once the disease ages, you're supposed to do a colonoscopy every year. So be aware that if there's a family history or people with a history of ulcerative colitis or Crohn's disease, they are at a slightly increased risk of colon cancer. Other things that you have to keep in mind is obviously genetic diseases, right? There are also patients who have these genes which they inherit, and I have had patients who are 15, 18 years old who have colon cancer, but again, it's all about genetic diseases, something called FAP or Lynch syndrome. But again, it's important. That's why it's very important to talk to your family and be aware of what's happening in the whole entire system, right? Some of the new factors research is now talking about is the microbiome, right? Or the gut flora, right? Everybody's talking about how healthy is your gut. So gut health is actually very important. And of course, microbiota is what kind of microorganisms are living in your colon. There's new theories about that, and also the other thing that's coming and emerging is antibiotics. Right? We are very used to going to primary care physicians. Give me a Z-Pack and give me my, Levittown because I have a cold, please. But there's so much resistance building up. But there's this new theory also coming up. The more antibiotics you use, the more risk factor they're creating. But that's a new research coming. More information is to be coming around. Next slide, please. Of course, Nilesh had talked about the ultra-processed foods, right? Nowadays, we are living in a community where we wake up, we don't have time to have breakfast. We take our bars, I have my granola bar, or I have this bars and that bars, and I'm done with my breakfast, and then lunch comes around, I have a little package, I warm it up in my microwave, and that's my food, and when I come home, whatever that I can quickly make is what I do. So unfortunately, this is, as you can see, this is a very cool study. If you look at this, there were about 30,000 women who were eating very ultra-processed food, meaning 10 servings a day. They had a 45% higher risk of precancerous polyps to be found. So in these patients, these women who were eating all these ultra-processed foods, on the go, the bars, the plastics, they were found to have more polyps compared to normal. So now we know that ultra-processed foods are not the right thing to do. If you look at this study, this is also a very cool study about microplastic, right? We're very used to putting our food in the plastic boxes and then leaving it alone and putting it in the fridge for storing it and etc. But again, look at that. I mean, there's a study which showed there's a 50% increased risk of colon cancer in patients who actually were using microplastics. So when people ask how come younger and younger population is getting more and more cancer, because this is how we're living. All we think about is let me quickly go to work, let me just get this bars into my system, let me drink a protein shake, and let me do my thing and I'm going to come back. So really diet does play a role, and it's very important what you put into your, right, am I correct Dr. Carla, right? Diet makes a world of a difference, so that's very important. Now, who knows about PFAs? I think everybody is aware about PFAs, yes? Yes? No? Let's talk. So there are, chemicals, right? They're simple, indirect chemicals. Most important in cookware, what kind of cookwares we're using, what kind of food packaging, and what are we drinking our water from. So those are things, they're called forever chemicals. And they are rated as number 1, group 1 carcinogen. So that's why you have to, and research, it's actually, they suggest that it causes the barrier of your gut, which protects your gut, it disrupts it. And when you disrupt the barrier of your gut, what's going to happen? You're going to have chemicals which are going to cause inflammation, which indirectly will lead to another risk factor for colon cancer. So these are the most common new things that, even though yes, we are aware, but now we're paying so much attention until now, because again, 45 is the new age, but these are things that are what's causing and driving colon cancer. So we all need to be very, very aware of this. Natural food, home-cooked meals are the best meals, in plain simple words. Next slide. Let's talk about warning signs, right? We did talk about a little bit in the beginning about how do you know, like what do I worry about, when do I call and talk to my physician, right? So most important thing, change in bowel habits. We just talked about how if you have, from your normal bowel habits, you have a complete change. If you start having diarrhea, which is unusual, if you start having constipation when you were never constipated, those are things, those are red flag signs. Wait, this is not my habit. Something has changed. I gotta go seek out my physician, right? Next thing, blood and stool, right? You should not have blood and stool. Another easy, simple thing to look at. And people do say, I don't look at my poop. I never look at my poop. But listen, sometimes when you're wiping, you do look in the toilet bowl. But again, be aware if there's any blood in your stool. go talk to your physician, right? Not all blood in stool is cancer. Blood in stool could be hemorrhoids. So it's still okay, but still you should bring and mention that to your physician. Unexplained weight loss, right? Here I cannot lose a single pound, but all of a sudden I'm noticing, holy moly, I'm losing 10 pounds. What happened? I didn't change my diet. I didn't change the way that I'm eating. I'm doing the same thing. I'm losing weight. So the most important thing that everyone here also, besides forget colon cancer, if there's any unintentional weight loss, you guys have to think something is not right. I'm eating everything, I'm eating normally, why am I losing weight? If there's no reason for it, talk to your doctor. So those are things that you have to be very careful about. Unexpected, unusual abdominal pain. You shouldn't have abdominal pain, right? Here and there, of course, if you eat bad, you can have abdominal pain, but you're noticing that you're having pain every other day. Even eating the simplest foods, I'm having cramps and pain. You should go seek out a physician, right? Iron deficiency anemia, we just talked about, right? When you go for your physical, you're noticing that your doctor notices your hemoglobin, your iron levels are low. That's another alarm sign, right? If you're feeling dizzy, lightheaded, not comfortable, fatigued, those are signs for anemia. You go to your doctor and check it out, right? Last but least, of course, that again, a big change is when you really are getting constipated, which is unusual. So those are things that you have to kind of keep on, just be aware of them. And don't be shy to approach your physician. You're not just going for your physician to get your blood work and get an EKG. Wrong. You're trying to sit with your doctor because I'm coming for a physical, and physicals are done every year. But listen, if you have a good insurance, you don't even need a primary care physician. You can go to the specialist directly. But that's not the point. But the point is to talk to your physician. Next slide, please. We always know that I always talk about what's the best gold standard test to do. It's a colonoscopy, right? When I do a colonoscopy, I'm visualizing every little fold in your colon. I'm looking at every little corner with my own eyes and looking for growths in your colon. So this is truly the best gold standard, or I call it the Mercedes of the test, or the Porsche of the test, right? People must have heard about Cologuards. Who's heard about Cologuards? Right. So how many people here have not had a colonoscopy and had a Cologuard? It's okay. It's all right. Listen, at least you're being honest, and it's an option.
You know why?
Yes.
Because I'm not 45.
You're not 45. You're only what, 25?
Yeah.
Oh, that's reasonable.
Please excuse.
But huh? You've not done Induchi.
We are going to convince everybody.
So this is what we're going to plan. Whoever's not had their colonoscopy, we're going to make a group trip.
Yes.
Let's do that. How cool would that be, right? We're going to make this as an Indian American forum colonoscopy day. Literally, I think it's good. This is you convincing. Think about it. You guys are like, I think, in every other organization. I can't even think how many organizations you guys run. God only knows how. But how cool would that be that Binaji, my darling, you should be, you lead, Jyotiji leads probably what, 100 million places. So
Actually, I have prescription 4 months back from Dr. Neela Patel to go to you.
Yes.
I have to come.
So when are we doing this? I'm available Wednesdays and Fridays. I'll give you where's the samples? I'm sorry?
I just wanted to take an appointment for my wife.
Yes.
And he says
We don't take any new patients.
new patient.
Who?
Jericho.
Jericho?
Jericho office. Where Dr. Mark is there too.
Dr. Mark Nitro is there. I'm there. We have like 20 doctors.
So she said that Dr. Mark is not taking new patient.
Oh, that's interesting. Listen, let's get an appointment today. Let's meet each other next Tuesday at my Jericho office. Done. So before we go, I'll give you that.
We have one more patient here.
Yeah, listen. But I think to be honest, because all of you women are so strong and you run so many organizations, let's be the example. Forget these slides. You guys are going to be the examples for everybody that look, I went, I did my procedure, it was safe, it was easy, and I drank the prep and I had no issues, and I prevented the most common colon cancer in the world, period. I don't need this presentation, I don't need to do this stuff. You are the examples and you will show that talk to everybody.
How often you have to have it in your life?
Every 5 years. So very good question, very good point. So, I'm sorry?
Could be 3 years too.
It could be three. So number one, colonoscopy in a patient, healthy 45-year-old with no family history, who comes and does a colonoscopy, has no polyps, no growths, and their prep is perfect and pristine. I don't see them for 10 years. So think about it. How easy is this, guys, right? Whoever's not doing their colonoscopy, if everything's perfect, I don't see you for 10 years. Goodbye. We'll see each other somewhere else, but
See you in the talk here or in the
we'll
park.
see you in like different, yes,
I
yes,
have
ma'am.
a question, like if you have a colonoscopy that was negative, everything was fine, then you went for a Cologuard.
Yes.
You went twice or 3 times.
Yes.
And then you still have to follow up with a colonoscopy after a certain time?
Very good question. So what happens is that again, that same patient who's 45 years old or 50 or whatever, whenever you did your colonoscopy, you're nice, you're clean, you're healthy, no polyps. I have to see you every 10 years, right? So, and also what ends up happening is that suppose if I find polyps, so the story changes and the timeline changes if I find polyps, right? If I find 1 or 2 little polyps, I don't have to see you for 5 years, right? But if I find multiple polyps, and if I find they're big polyps, I bring you in 2 years or a year. Or if the polyps are very highly dysplastic, meaning they have a high chance to become into cancer, they come to me in 6 months. I'm going to show you some nice interesting pictures or videos just to kind of show you what a typical 45-year-old is and what the colonoscopy looks like and how we remove it. But it all depends on how many polyps I find. But majority of the patients, and Dr. Arya can vouch, are screening colonoscopies. We don't see for 10 years. I mean, how simple. One time you have that little bit of pain, which is drinking that medicine, but I'll talk to you about this too. So, but I think I urge you to really, my team, do it and be the queens of the organizations and show that you did it, right? Queens of Long Island or whoever. Let's go. So,
It's like 60 plus 8, and if you don't find anything, it's still the same time?
absolutely. So you keep going and doing up till the age of 75. Now, I'll tell you a new twist. Are people living longer?
Yes.
Exactly. So thank you. People are living longer. So my very highly educated, intelligent, smart, I'll say my cute little Jewish ladies, they're like 85 walking in my office. I want my colonoscopy, Dr. Mehta. I'm alert, I'm oriented, my mental status is good, I want to live longer, I want to be with my grandkids. And I say, yes, you should. Now, so I don't stop at 75. The new rule is that if the patient is healthy, can tolerate anesthesia, and is not going to die for the next 20 or 30 years, you do that. So technically, there's no age limit. Yes, we do say 75, but again, individualization. My 85-year-old, the Jewish lady, I just finished this morning, I found 2 polyps. My 90-year-old, no, again, you also have to be good doctors, skillful doctors. You have to know your limit, right? You can do the colonoscopy nicely, carefully, methodically, making sure that the patient will tolerate anesthesia because it's an outpatient procedure. You don't want to do any harm. There should be no wrong indication. There should be no easy, oh, this is a colonoscopy, this is not money. No, you don't think that. So that's how you have to treat your 85 years, so there's no limit. But I know you're gonna get bored of this. Cologuard, obviously it's a box that you get in your mail, right? Am I correct? And then you take the stupid things and put that poop in there.
How reliable is this test?
I'm sorry?
How reliable
What a
is
good
this
question.
test?
Look. You look at I love my audience today. This is so good. But look, so Cologuard, it detects only 42%. Can you imagine? Only 42% of the precancerous polyps. What about my 58% of those polyps? I'm going to wait for those polyps to turn into cancer?
So why the people are pressurizing you to go for this screening test?
So that's where we need to educate our primary care physicians. That's where we're having these lectures. I've had, and think about the unnecessary headaches patients get. I've done so many colonoscopies on patients with Cologuard positive test, and their colonoscopies are completely normal. So think about that patient who comes in so much stress. The patient's crying in my office.
Keep on sending the kit to you and.
So that's what I said. Today you're gonna say, doctor, I want the Mercedes of the test. I want the colonoscopy, so that I don't have to do this damn thing for the next 10 years, right? And think about it. I don't want to miss polyps.
Yeah, I got it done also.
Right. Thank you. I appreciate that. But it misses. Think about the false positive rates. Oh my God, 13% false positive. Think about the anxiety that these patients are. I've seen when patients come into my office and they're crying, Dr. Mehta, I have cancer. My 45-year-old getting a Cologuard. How ridiculous. Why? You're a healthy 45-year-old. Go get a colonoscopy. Get tolerate anesthesia. It's a one-day thing.
Insurance doesn't pay for 45 years.
They do. They're doing it. And primary care physicians, just to meet the metrics, so they can get that extra dollar, are recommending Cologuards.
Yeah.
That's it. So the thing is, primary care physicians are also, they have to meet certain metrics by the insurance companies. So they are forcing patients to, whatever quickly will be done so that they can meet the metrics, so they can get the value-based money at the end of the year. But again, not a big deal, listen. Whatever it is, you don't knock anybody, whatever it is. But I want you to be aware that, look at this, 8% false negative.
Yeah.
Like, how crazy is that? It can miss real cancers. So then, and last but least, if the Cologuard is positive, do you not have to do a colonoscopy? Right? How silly is that? So why would I send my, so I would send maybe my 85-year-old, my 75, who cannot tolerate anesthesia, who's short of breath, who's having chest pain, who has neurological event. Those patients understood, right? Because I don't want to put them to risk of anesthesia. Those people make sense. You have to have the right criteria and the right thought to do and recommend that, right? So I recommend young people, and nowadays young is, it's all a number, right? You know, 65 is a new 55. Come on, I mean, I'm 51 years old, but I feel like I'm 21 years old. I can do anything, you can conquer the world. So age is just a number. So that's why I'd say that, listen, get that thing done. I don't like this study. I don't like Cologuard. It's not my preference. At least someone did it, and you're at least being proactive. So there's nothing wrong, but we want to be careful, right? Next slide, please. So here we go. We already have, how many people today we're going to all together get the colonoscopy done, right? So we got to take the action today, right? Let's go to the next slide. This is it, okay. This is the picture. I'm going to just show you, just to kind of put everything in perspective, right? To show. So again, please pardon, it might be, so what do you, as I'm doing the, look, I'm looking inside the colon. You see that little lump?
Yeah.
Do you guys, now pause it please, pause it, take the snare, literally go back please. But that's it, stop, pause. You see that? So this is my tube, it's a long tube, just like this. And this long tube has a camera. And I'm going from the rectum and going inside the colon. And this is my scope looking, and I'm looking at each little corner and fold. And you see this is a polyp. This is what a growth in the colon looks like. But this growth, if you leave it alone, in the next 10 to 15 years, it will become into cancer. And this is my typical 45-year-old female who came in for a simple screening colonoscopy. So, what I did, go ahead, please play. And now how?
What about the small particles of the polyps inside there?
Which ones? This is just light reflection. This little thing is just another polyp that I took out before.
The white one.
Oh, these?
Yeah.
These are just light reflection. The camera is reflecting light.
Okay, so these are the polyps.
Yes, so this is what, now look what I'm doing. I'm taking a snare, I'm lassoing the polyp. Now watch, I'm going to start closing. I'm going to use electrocautery. Look at that, right? Pretty decent sized polyp in a 45-year-old. I'm going to cut it. And it's gone. Now watch what I'm going to do. I'm going to suction that tissue into my scope, and it's gone. And that's what's left over. So Just pause it for a second for me. So this is what a simple colonoscopy does right now. This 45-year-old who came to me didn't have any symptoms. She didn't have bleeding. She didn't have a change in bowel habits. She wasn't anemic. She didn't have any abdominal pain. She had nothing. But we found a pretty decent sized polyp, right? Keep going right here.
What happens to the polyp? Was it cancerous?
So the polyp.
Biopsy, we have to-
So that's a good question. So we take that tissue, we send it to the pathologist, they look under the microscope and they tell me, Dr. Mehta, this is precancerous. So these polyps are different types. So polyps, I like to call them, as me and Nilesh both like to call them, as pimples. They literally look like zits in your colon, little pimples in your colon, right? So when we cut them, we take the biopsy, we send it to the pathologist, and there are different types of polyps, right? One polyp is something called hyperplastic, meaning zero cancer potential. This polyp came back as precancerous, right? And that polyp was, the official word is it's called the tubular adenoma, precancerous, right? But again, not cancerous, but precancerous, not cancer, right? So it was removed, it was suctioned, it was gone. But again, in this patient, let's see, this is N, right? Is it?
Yeah, it's a nice.
But, and now can you go to the next? Is there, close that? Yeah. And then there's another, there's, what, escape? Go back this slide. No, there's one more video I
One more
attached.
polyp before this.
Yeah. Let me see. Play. Can you play that? Is that the same that you?
No,
It's different, right?
yeah.
The same thing, another polyp, right? Again, the same thing, there we go. Now watch, it's a very flat polyp. But again, as I'm just using, it's a typical lasso. I call it the Texas lasso. We lasso this, we burn it, and we remove it. Again, this patient, asymptomatic, but I'll show you something very interesting in this 45-year-old as we're going along. Again, good, right? Now we're just gonna cut it, burn it, and then again, same thing, pretty decent size, right? But this 45-year-old had a very interesting, this is the second video you showed, correct?
Yes.
Good. So I'm burning it, that's gone, and that tissue is going to be suctioned in. Now watch, I'm going to start coming back. There's a little nibbit right there also. You can fast forward a little bit because I want to show something a little bit more interesting. A little bit more, yeah, go ahead. Yeah, just, again, I'm just chopping away at that polyp and removing it, right? And keep coming back. You can go forward, 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 a little bit forward, 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 forward. That's it. Can you just go back to the slides? I hope I'm not boring you guys, yes? No, you guys are very interesting. Yeah. There was a very interesting, can you just, yeah, I thought it was a bigger one today. Can you, there was a, yeah. I'm sorry. Oh, that's right. I was going to show some more interest, but I had another 45-year-old that I just spoke today. Asymptomatic, as I'm scoping, I took out 12 polyps. Wow. 12, there were 12 polyps, and one polyp was a tree. Tree, when I say, I'm so sorry, I'm going to show an example. If this is the stalk, this was the head of the polyp. So imagine this polyp was sitting and flopping back and forth.
Oh my God.
And this big, 45-year-old. And so I kept on asking my technician, can you please review my notes to see if I missed something? Because it was just shocking. This patient had no family history. No family history, no smoking, no drinking, not obese, not alcoholic, no symptoms, no complaints. Just came in for a routine colonoscopy. It took me almost an hour and a half to do a colonoscopy, but I was able to remove the big polyp, and when I removed it, I had to put 5-6 clips to close that area. But the point is, I've also had many 45, 50, 60 years old who's had beautiful colonoscopy. So this is not to scare anybody, but what I'm trying to say is that it's reasonable and it's important to really do this test, right? No scare tactics here whatsoever, but I wanted to show you what we do, just to put things into reality and perspective. Can you go to the next slide, please?
That was the last
That was the last slide. Okay, good. Perfect, you got it. Now, questions. Let's talk about these preps. Yes, this is that gallon, which is 100 years old. If anybody gives you this, leave that doctor. I'm so sorry. Because this is no longer the standard of care, right? The new prep, you just open it up. This is the new prep, which is called SUPREP, because everybody hates doing the colonoscopy because they have to drink the prep. But nowadays, look, these 2 little bottles, that's it. And this is the little cup. You pour this medicine, you drink this at 6 p.m. and you drink the second bottle at 10 p.m. Simple 2 little bottles compared to that monster. So what has really ruined the name of colonoscopy is that jug. Yes. Right? Right? It's a torture. So this is the newer prep, small and easy. Right? Now I'll tell you there. Yes.
You have to add water to this?
You have to add water. Absolutely. So this is 100% engaged. So what we do is we pour this in. So this is about 6 to 7 ounces, and we mix it up to make it into a 16-ounce cup. So it will be a 16-ounce concoction. This plus the water, you drink it over 1 hour, and then 4 hours later, you drink the second, same thing. Now, does this taste good? No. It tastes, to scare my patient a little bit, but to make them feel comfortable, it does taste like Jones Beach water with some Robitussin. So understand that. However, when I say that, I also with the same breath tell them this is an extreme exaggeration. I take it, I put it in the fridge, make it nice and chilled, put a straw through it, so I never taste it on my tongue. It's a straw that I'm drinking it with, so I don't taste it. Simple. So you have to make the patient aware and understand, so when they're actually doing it, they can come back next day and say, Dr. Mehta, it was not bad. You know, Dr. Mehta, they made it seem a little bit more uncomfortable. But this is the newer one. The latest is pills. Like for crying out loud, pills. It's 2 little bottles. And each bottle does have a lot of pills. It has 12 pills each. They're like little multivitamin pills. I did the pill prep. You did the one. Which one?
I did that.
I can't drink so many pills. I just prefer drinking this. I don't mind the taste. I just chug it down, and I didn't mind the taste at all. Some people who are very sensitive to a salty taste probably will complain about it. And I have some people who say, I can never drink salt water and throw up. They take the pills. So it's your choice, it's your personal preference. Most people know what they can tolerate in terms of taste. But it's much better. It's much better than this.
The pills, I'll tell you my experience was easy. Jyotiji, I'm counting. Wednesday or Friday, 6 a.m. I start at 6 a.m. So,
4 hours in the evening. When do we start?
So the way to do a prep, very good question. So what's going to happen, say Jyotiji is coming on Wednesday. So Jyotiji on Tuesday will be on a clear liquid diet. Now what does clear liquid diet? And Jyotiji's lovely husband, 100%, both. I do couples. Me and Nilesh even were requested, listen, you do the husband, I do the wife. Totally fine. We're totally fine with that.
It's a very romantic prep. The wife gets the bathroom first.
So what's
the bathroom when they're doing this. So okay, explain the prep sounds very simple.
Yeah.
and I'm not going to tell anybody don't do it, but you have to be prepared to sit in the bathroom. The result is the same, whether this or this, that you gotta clean your gut. You have to do it, and Gatorade you have to drink. You may not like it, sugar-free Gatorade available. It's a must. Prep is so important because like he said, if no good prep, you'll have to do it again in 1 month. Who wants that? So do a good prep, sit in the bathroom and enjoy your company.
So as Jyoti ji were saying, absolutely, Dr. Carla said, one day before, like I said, Jyoti is coming at 6 o'clock on Wednesday morning. The appointment is set. So Tuesday, she's going to be on a clear liquid diet. That means coconut water. That's my favorite. Dr. Carla said, ginger ale. Absolutely, we have a lovely dietitian. Now, what I do is I don't like Jello too much. You know what I've been noticing with Jello? It's sticky, and it kind of in the cecum gets coated with yellow cecum. And I want a cream prep, so I tell if they are really desperate to having something to have the food, then I say Jello. But majority of them, I say, let's in the morning have your tea, have your coffee, put some little milk in, I don't care. But coconut water is key because it has all the electrolytes, right? Gatorade, electrolytes. Nowadays they have this IV liquid. Everybody's into fashion IV liquid. Hey, listen, just make nimbu ka pani and you're all good, right? Nimbu, put some lemon, put some sugar, put some kali mirch, and you're all set to go. That's your Gatorade. So the point is that you're going to drink clear liquid, right, Jyoti ji, you're following.
Yeah.
She's scared.
But Jyoti's going to do the pill prep. So it's just going to be one bottle starting at 6 p.m. That bottle has 12 pills, simple 12 pills. She'll between 6 to 7 p.m., 1 hour, one pill at a time. Every 2-3 minutes, you take it, and that's what I did. 2-3 minutes, I took a pill, I walked around, I said hello to my kids, I sat with my daughters studying for some AP bio stuff, went back, and then I started drinking fluids. In about an hour later, so between 8:30, I had the cramps, right? I had the cramps, I had to go. All right, I went, came back, oh my God, more. So again, it's almost like I'm giving you the bad food. But again, it's not as bad where you're throwing up and going from the bottom, not sick like that. But you have the cramps and it's inducing it, right? And you repeat the same step at 10:30. Take the second bottle, take the 12 pills in an hour and drink lots of water. And I tell my patients, you and the bathroom are going to be best friends, and it's okay. Listen, get your phone ready, get your magazines ready, get your youth soap operas, whatever that needs to be. That's going to float your boat, but yes.
Question, between the liquid and the tablets, which one of them would give you less cramping?
Same.
But is it tolerable cramping?
It's very tolerable. To be honest, it's just you have this feeling, oh my God, okay, I just went, oh my God, I gotta go back again. Oh, I gotta go back. It's not like you're twisting it like when you have a bug, not those kind of cramps, but that feeling, oh my God, I just finished, I gotta go back, right? And I tell my patients also, important thing is, remember, when people are giving instructions, the doctors again, or whoever's giving the instructions, your MAs, your PAs, your nurse practitioners, you have to train them to give them proper instructions. If you're going to gulp this thing quickly, you're going to vomit. I had one of my patients yesterday call me at like 1 a.m. in the morning or so. Not 1 a.m., I'm so sorry, it was like around 9 o'clock. She called me, said, Dr. Mehta, I drank it very quickly. I was like, no, you were supposed to go slow. But she said, oh, I didn't want to wait so long. But then within half an hour, she up-chucked everything. So slow and steady wins the race. That's right. So that's how we do it. And the next day, you come in, we have our lovely nurses, they put an IV, the anesthesiologist comes, we give you propofol. It takes me about 30 to 40 minutes to look at the colon, and within 30 minutes you wake up and you go back home. So it's very, very simple.
When do you start liquid diet?
The whole day, the day before. The day before, 24 hours. Right? And that's where I also run into a lot of problems is that some people cannot do that and they end up eating, but then again, same thing Dr. Carla said, you are not clean, see you soon again, right? So that is
Why should be like that? Like you have to start using the nurse like a week before. that you can't have nuts or anything a week before?
Oh, that, see, the thing is that, see, it's usually we talk about like too many seeds. It's not silent you have, but the seeds are what causes the issue, you know. So we do say try to stay on a low fiber diet so that the cleanse is better. Yes, yes, sir.
This has to be done without the anesthesia?
Yes. So where I was trained in upstate. So I had to cover 3 hospitals. Me and my husband did my fellowship together. So I used to cover the VA as well, the veterans. And my veterans didn't have any family members to bring them for their procedures. And you need someone to bring you because of anesthesia. So my veterans would just come in, they said, Dr. Mehta, totally fine. And I scoped them easily. I was taught, I think I must have done
I did without anesthesia.
Exactly. You can't, again, remember, the doctor must have... Yeah, exactly. Yes, Rita. Yes.
The comment is very...
The tablets are chewable or swallowing?
Swallow. But I'll tell you one more thing, Rita, I want to say. So if people cannot do this or the pills, we have other ways. So the other ways are we do something called the Miralax prep, right? Miralax is over the counter. You can take a nice bottle of Miralax, which is about 238 grams of powder, mix it with Gatorade, you mix a solution and you drink it. It has no taste, no pills, nothing. So the important thing is whoever your gastroenterologist is, they need to sit with you and tell you that I have all these options. If you cannot do this, let's try the Miralax prep. If you cannot do the Miralax prep, let's do an enema prep and 2-day diet. If you're constipated, let's change your prep. So you have to have the flexibility, the maneuverability of changing the prep. Don't let the patient walk out that because of the prep I can't do it. I have patients, Nilesh has patients, they call them all the night. At night we are getting calls, Dr. Mehta, I cannot do this. But listen, you've been already on a liquid diet. You spent your whole day, you took a day off, you had your husband take a day off, and then you're telling me you're not going to come? Listen, let's come up with a divisive plan. That night, in the evening, I remember yesterday, Nilesh called the patient back up. Remember, you said, listen, go to the pharmacy, go get Miralax, go get a little bit of Dilcolax and take a little enema and you'll be set. She came at 6 o'clock in the morning, clean. So important thing is also you have to be a human being, not just a doctor, right? To be a human being, to think what the patient is going through, right? You have to be kind, you have to be giving, you have to be listening. You're not just a person who's coming in for a school, right? So, yes, you were saying something.
The first comment is that you did a fabulous job in making everybody feel comfortable. And the second comment is that I do not think anybody picked up. You used the word find the skilled physician. It is very, very important, but because they were title of the physicians, everybody is not going to deliver the same thing. And the other thing also I want to mention that there are so many community leaders are sitting here. They are organizing and first, they could be listening to the slide, to you, looking at the slide, but if they are not going to practice it and continue to get the soda, it's not going to work. So those are the things that we really have to practice after a while. And like the dirty diaper, stay away, water bottle here. It's a simple thing, just tell the people, bring the water with you. So they can drink the water, you don't have to supply the water in the glass. These are the simple things that we need to change what we need at this point. If we want to correct the situation. Do you mind mentioning two things for the community's education? Number one is on H. pylori and SIBO and SIFO. Because those are the things, and as an RPQNI, every month they are having the physician education. This is a colorectal cancer. Why don't you guys go as a doctor? That is a very, very good. So I think we should educate the primary care physician. And in that MSQ, they should add this because nowadays every patient is asking GI. So where is your brain right now? I'm just saying you should talking to the primary care physician.
Absolutely, 100%. Education is key to success, and obviously we want to make sure that we try our efforts, we physicians. But I think, listen, I think we have about 40 people here. I want you to go and communicate and give this message to everybody and all, right? Sharing is caring, educating is important. For me alone, or Nilesh alone, or Dr. alone, Carla cannot do it, but we need you guys to support us, talk to everybody, and go from there.
I have one question.
Yes.
Let's touch upon the insurance.
Yes, so very important. Most important thing is that with insurance, so insurance absolutely made a very good point. Screening colonoscopies are all covered by insurance.
Yes.
Let me tell you the second point. Screening, there's a code, specific prevention. When you put that code, even if you have a deductible, you don't have to pay. So your doctors ought to make sure that they put prevention as the code, and you will not have to pay a dime. So for a colonoscopy, so most insurances, like commercial insurances, you don't need any referral. You can just go to the primary care. You can go to the gastroenterologist directly and schedule yourself. There are some Health First, Fidelis, other types of other insurances that may need coverage or a referral by a physician, but most of them don't, because this is your prerogative. It's the doctor's, it's the insurance company's interest, because if they miss that colon cancer, then guess what? The patient has to go to surgery, then they have to be hospitalized, then chemotherapy, then radiation. Think about the amount of money that they have to pay versus just get the damn colonoscopy done.
We can just walk into your office and get it.
Absolutely, 110%. We'll be there for you.
Preeti ji, thank you so much. Before I go further, Flora has few words.
So, first of all, how about a huge round of applause for the young doctors? And a huge round of applause for our live lady, who I like to always call my live lady, a source of powerhouse, a source of inspiration. I don't know people, and I wouldn't even call ourselves leaders, because we have a long way to go. If you want to see a leader, it's right here. So there are a few leaders who go ahead and develop and who give rise to leaders, and she's one of them. Thank you for making this very informative. This organization is doing some amazing work with the amazing help of all of the people here. Vimalji is here. Dr. Sanjita, our media group, is also here. Dr. Karva, the lovely doctors, and more importantly, all of you. I have just one comment to say. Doctors, so you mentioned a good point. You have to look for a skilled physician. You have to look for somebody who is friendly. You have to look for somebody who is in a driving distance, somebody who has offices all over Queens, Nassau, Suffolk. You have to look for somebody who is family oriented, who you can feel comfortable calling in the middle of the night and say, "Oops, that liquid did not work. Why go somewhere else? It's right here." And that's the best introduction I can give for Dr. Nilesh and Preeti. These guys are not only available for their practice, for the topic they teach, but I know my son is a doctor, and I have no idea how many times he bothers them through the middle of the night, through every stage, whether it is residency, whether it is fellowship, anything, he just goes ahead. Nephrology. And he bothers, and they're always there. They're always there guiding us. You guys are amazing, and they're parents of 3 lovely kids also. So if you tell me, I was asking them when we walked in, what is the fun fact about them? They're like, we have 3 kids. Do you need any additional fun facts? But jokes aside,
Dr. Nilesh, I know he's a lovely photographer. He loves photography. I don't know where that came from. He has a lovely wife, I think, because, and she's very photogenic. So I think that came from there, and they are very family oriented guys. The office list that you see on here is not it. By the time you have the next lecture, there will be like 10, 15 more on there. They grow tremendously. Why? Because they love what they do. They are passionate about what they do. They really do what they do.
Thank you, Shora. And while Dr. Preeti Mehta and Nilesh Mehta, they are here, look at oh my God. Dr. Arya, our grandfather of GI. Would you like to say a few words?
As usual, what I expected from Preeti, a fantastic talk. And the most important, what I noticed, that the points were very convincing. I'm a retired gastroenterologist. I retired 3 years back. And the most important problem for colonoscopy is, number one, yes, everyone must have. Everyone must have. Second thing is hesitancy. And I'm telling you here in front of you a true story, which is one of a very senior member of our community. I cannot spell his name, but I got a call from his wife. इनकी तबीयत ठीक नहीं है, ये बाथरूम बहुत कई बार जाते हैं. Tomorrow we'll do a colonoscopy. We booked it, he cancelled 3 times. 4th time, he saw some blood in the stools. The wife calls me again. That's why we थोड़ा blood आ रहा है. Don't be nervous. Let's schedule him. वो कहता है डॉक्टर साहब मेरा अपॉइंटमेंट ले लिया है, मेरे को इंडिया जाना है, मेरी फ्लाइट बुक है. Man, don't worry, you take the preparation. I'll bring the scope to your house. I'll bring the machine, I'll bring my nurse, but I don't want you to suffer anything. Anyway, next day when I called his son, that do you want me to come to No, you don't have to do that. He brought him to my office. I did a colonoscopy. We found a large precancerous tube. Wow. His life was saved. And now whenever I meet, that's how I'm living because of you. No, you are living because of the God. That's not. So what I'm trying to tell, that he made a very convincing point, but one must have a colonoscopy at least once in his life.
Thank you for your
Yes, thank you, Preeti ji, thank you, Dr. Mehta. Thanks to all of you for coming. We also have to acknowledge our members who are here today. We have Deepak ji, and from our IFCJ program, Deepak ji, and then we have Govind Gupta ji, ILI Vice President. And we have Sujata ji just came in from Parker Jewish, our biggest supporter. Thank you so much. And over here, Dr. Saluja ji, he is so busy. Thursday no one look all se nikal nahi sakte. So when I said in Dr. Sahab Padagara Kola, you must, I don't know Punjabi, you must come. So we want to thank you. And Tanuja is from the Caribbean City Network. So when she heard we were doing this program, thank you Tanuja. Suhag Mehta is there in the back, does the big Ganesh program. And of course we have Rita Batija and Veena ji and Jyoti ji and Jag ji. Thank you. Okay, now Jag ji, you want to do the closing remarks?
I just want to conclude, colon cancer is curable. Even if they find late, we have latest immunotherapy. Don't even call it chemotherapy. We have so many new markers. It's just amazing how oncology is growing. Colonoscopy can be done, and then we can find what we find. If it's a polyp, great. But if it's an early cancer, treatable. If it's a late cancer, still treatable. It can spread, still treatable. So colon cancer awareness was great. And please, anesthesia is beautiful. You get such a good sleep. I love it. Hanji? Oh, Saroji, thank you for coming from one program to another. Oh, I love this. You know, this audience is really beautiful. Thank you, all of you, for coming. Rimaji, colonoscopy convinced. And thank you everybody for coming, and thank you, both of you. Thank you, IAF. Thank you, Flora. I am really impressed with Induji and of course everybody else arranging this program. We are wonderful.